Welcome to the Learning Lab. My name is Roman Garcia. Now, as I accumulate years in the field, and accumulate data, what I start to realize is that there are certain patterns that are very consistent with individuals who have common ailments. Now, one of these patterns that I have recently documented with accumulation of data is the relationship between the anterior cruciate ligament and individuals who have knock knee. Now, it appears that those individuals who have knock knee, the anterior cruciate ligament, otherwise known as the ACL, when an MRI is done of those individuals, in many cases, the MRI always comes back as the ACL having some kind of tear in it. Now, what I've noticed is that when you read the MRI and then you do the physical examination, both do not jibe. In many cases, when you do anterior cruciate ligament testing on these individuals, clinically, that knee responds as if the ACL is not torn, yet the MRI is coming back and showing that the ACL is torn, creating tremendous grief for the patient. Now, what I'm going to show you in a little bit is why this discrepancy between MRI and clinical findings is arising in these cases. Now, what I want to do show you first is how the course that the ACL has in a normal knee joint. Now, Carlos, if you can come over here, what I've drawn here is how the ACL courses, the direction the ACL takes in a knee. This specifically is a right knee. This is the upper bone, this is the lower bone. This black line right here, this represents the ACL. The ACL goes from the inside to the outside of the knee. To the outside of the knee. It goes from inside out, it moves up in a diagonal plane. Now, this picture right here shows a knee that's in neutral. It's neither knock knee nor bow-legged. In a knee like this, the ACL will give a representation on an MRI that's probably true when you examine it clinically. Now, let me show you what an ACL, the direction the ACL takes on a knee that's in a knock knee position. Now, this is a knee that's a knock knee. Again, this is the right knee. This is the ACL right here. You can see it's knocking in. And now what you see here is the ACL. Now, the interesting thing is that mechanically, most likely, a knee that's a knock knee will have a certain strain pattern on that ACL, which is very different from a knee that's either in neutral or one that's in bow-legged. Soon I'll show you a bow-legged knee drawn. Now, the interesting thing is that the ACL in a knock knee will be separated each end from each other because the knee is knocking in. Now, what this does is that it produces a constant strain load on that ACL. Now, let me show you a bow-legged knee pain. A bow-legged knee. Again, this is a right. This is the inside. This is the outside. This is a knee that's bowing. It's doing this. It's bowing. Now, when a knee bows, the inside of the knee, this is the inside, comes together. Since the ACL courses in a diagonal plane, it literally brings both ends of the ACL closer to each other. In effect, it shortens it. So there's no tension on the ACL as you will experience a knee that's in knock knee. Again, since the inside expands and the outside closes, the knee in essence is doing this. It's bowing in. It's knocking in. So it actually brings both ends farther apart, thus stretching the ACL on both ends. A ACL that's in a knock knee will always be under a constant strain load. Again, we'll go back to the bow-legged. Again, the strain pattern is different. Both ends are brought closer together. So this ACL is not under a tension type of stress. And I believe that is what causes the tissue state of the ACL to differ between a knee that's in neutral, in bowing, or is in knock knee. Now, why is the MRI always comes back with a description? Carlos, you can come to me. Why does the MRI always comes back with a description of an ACL that's either torn or showing some inconsistency in its fibers? And the reason is that because the way that the MRI produces a picture. So what I want to do now is I just want to give you a real quick physical study, lecture, explanation on how the MRI produces a picture. This is MRI 101. This is very simple. Now, MRI means magnetic resonance image. Just the name magnetic gives you an idea what it actually, an MRI does and how it produces an image. It produces an electromagnetic current inside, or an electromagnetic field inside the tissue that's being radiated by the MRI energy. Now, the MRI manipulates just one atom in the human body, and that's hydrogen. Hydrogen is it is the simplest atom that exists in the human body. Every molecule that makes up human tissue or animate tissue will always have a hydrogen atom inside its molecular structure. Now, a hydrogen atom is very simple. It has one proton, one electron spinning around it. Now, what the MRI does is real simple. Creates an electrical field. It creates an electrical field inside the body. It agitates the hydrogen atom. So this electron, it agitates it to a higher energy plane. Basically, that's what it does. That electron, it takes it to a different energy plane than what it would naturally exist. Once it does that, the MRI shuts the electromagnetic field off and relaxes it. Once that electron that has been pushed to a higher electrical field or plane relaxes and comes back to its normal energy pattern, it releases an energy wave, which the MRI captures and formats into a picture. Now, that's in essence, that's what an MRI does. That's how it formats a picture. Carlos, you can come to me. It excites a hydrogen atom. It relaxes it, and when it relaxes it, the hydrogen atom releases an energy field, an energy signal, which the MRI captures and formats into a picture. Now, why is that important? It's important because a knee that's in a knock-knee stance, this anterior cruciate ligament, its molecular structure is different because it's always under duress. So the molecules in this ACL have a different energy pattern than a normal non-stress ACL. So when this ACL goes under an MRI and gets excited, the signal that it emanates is one that the MRI is formatting into showing it as if it has a tear. Carlos, you can come to me. So again, why is this important? It's important for just one reason, is that if you have a knock-knee pattern and you have an MRI done, and the doctor, once he reads it without checking you, tells you that you have an ACL tear, and you know that you're in a knock-knee pattern, do not believe what that MRI is saying until it gets confirmed by a clinical examination. Now, I've seen hundreds of these cases before where the MRI and the clinical exam do not jive. What is the truth? Is it the MRI or is it the clinical? My opinion is the clinical examination is what tells you if your ACL is torn or not, if you have a knock-knee position or knock-knee stance, alignment issue. Now, what I'm going to show you here, I'm not going to show you, I'm just going to read. These are just two cases of MRIs that patients brought with them before I examined them. and they both show ACL tears. Now, these are just 2 out of hundreds that I've seen. They both show ACL tears. Now, just like every other case that I've examined, when I examined these folks clinically, they demonstrated that their ACL was intact. It was not torn, yet the MRI showed that it was torn. Now, the problem with this is that it brings tremendous amounts of stress to the patients, because the only thing that concerned these patients when I saw them was that their ACL was torn, and they were recommended that they should have ACL reconstruction. Now, the problem with that is that if these individuals would have undergone these ACL reconstructions, the doctor, the ortho, when he would have gone inside, he would have seen an ACL that probably did not look normal. Yet, he would have replaced it anyway because of the fact that it did not look normal. Its state, probably under visual examination, would have shown a suspicious ACL. Yet, that ACL clinically was functionable. So the morphology, the shape of the ACL, does not necessarily always predict whether that ACL is functioning or not in that knee. And in these 2 cases that I saw, of which there are hundreds of others, the ACL in all cases does not need to be replaced. Now, what I'm going to do now is I'm just going to show you a simple ACL examination with the help of my assistant, Anna. Now, there are many tests for the ACLs, and we've gone through this before. Ana, muévete para adelante un poquito. Así, okay? Relájame. Now, I just need 2 tests to determine whether an ACL is torn or not. 2 tests is all I need. Now, the first test that I do, this gives you an idea. It's not very sensitive, but it gives you an idea. I internally rotate the tibia, and very simply I grab the lower bone, and very simply just pull, I pull the tibia forward. I always compare both. It's very rare that you would see somebody that has, it's very rare that you will see anybody that has 2 ACLs that are compromised. So there's always going to be a normal, and that's always basically your ruler, your measuring standard for that particular patient. Now, Anna, we already know that Anna is not knee. If Anna were to go and have an MRI, I would bet anything that MRI will come back with some description of abnormality in her knee. Yet, functionally, this knee has a stable ACL. This tibia does not glide forward excessively. Now, the second test that I use, this is the one that's more sensitive. This is the one that's more sensitive. This is a very common ACL test. You grab it, stabilize it at the femur, at the long bone right over here, and just simply snap it up. In an ACL that's intact, you're going to hear a click, and you're going to feel a sudden stoppage of this tibia moving forward. It's going to catch, basically. It catches. That's the ACL, preventing this bone right here from moving forward. Her ACL is completely intact. Now, again, come to me. Now, of course, again, I would bet anything. If Anna were to go do an MRI, if she's just walking around, she twists the knee starts hurting, gets a little bit swollen, she goes do an MRI, I would bet anything that MRI will come back with some description of abnormality in Anna's ACL, because Anna is a knock knee, so her ACL is always under always under tension whenever she's on her feet. That's going to change the molecular structure of her ACL. So that ACL is going to give off a signal, which is going to be interpreted by the MRI as a picture of a torn or disrupted ACL. Now, what I want to do now is I just want to show you an x-ray so you can see the forces at work between a knee that's in a knock knee and a knee that's in a bow-legged stance. Now, what you've got here is same person, right knee, left knee. This person is symmetry breaking, which, as in other videos that we described, all that means is that one knee is in knock knee and the other knee is bow-legged. Now, what I did here is I diagrammed the direction of the ACL. This is the right knee, this is the left knee. This area right here, this is the ACL. This is the direction of the ACL, right over here. It goes from the inside, outside. Now, this knee is a knock knee. Now remember, a knee that's a knock knee bends inward. So when it bends inward, the outside comes together, the inside comes apart. When that happens, both ends of the ACL are separated from each other. The direction is this way. This is what this arrow means. The direction is this way. This knee, this bone right here is going this way, this one's going this way. So the direction is this way, which what that does, it separates both ends of the ACL. The upper end of the ACL goes out, and then this one goes this way, diagonally. So the ACL gets stretched versus a bow-legged. This knee is in a bow-legged stance. Again, the direction of the ACL is right here. So since it's actually bowing inward, the inside of the knee is coming in. It brings both ends together. That's what this arrow represents. So, and what this arrow represents is the force of both ends of the bones coming together. Come over here again, Carlos, to the knock knee. In this case, the inside of the knee opens. So both ends are moving away from each other. In a bow-legged, both ends are moving towards each other, and that's what these arrows represents, thus bringing both ends of the ACL in a knee that's in a bow-legged stance, they come together. So there is no tension on the bow-legged knee, on the ACL. But there is, come to this one over here, Carlos, the knock knee, there is tension on the ACL, on a knock knee. That changes the molecular structure of the ACL because the tissue is always, and it has always a low-level inflammation inside it. The MRI interprets that signal as a torn ACL. Alrighty, so you can come to me now. So basically, what did we learn today? What we learned today is that if you're walking and your knees are in knock knee and something happens, you twist it, you fall down, the knee gets swollen, you go see an ortho, you go see your doctor, they do an MRI. The MRI comes back, tells you, lady, mister, you have a torn ACL. Do not be overly concerned with that diagnosis if your knee is a knock knee. Not until that knee gets evaluated clinically and the instability is established during clinical examination, you cannot believe that MRI. So do not allow any type of surgical procedure based on only a diagnosis from an MRI when you have knock knee and the diagnosis is torn ACL. Because the MRI is seeing the ACL in a way that does not, in most cases, does not jive with reality. Again, as we've always said, if you see this video and you have any questions about this video or any of the other videos that we produce, just feel free to give us a call. The phone number is always accompanied by the video. And for anybody that sees this video, we want to thank you, and hopefully this information will serve your purpose. Thank you very much.